Hello, my name is Makoto Mori. I am an associate editor at JACC and an assistant professor of cardiac surgery at Yale School of Medicine. Today we have a pleasure of having Dr. Catherine Wagner. She is an integrated cardiothoracic surgery resident at the University of Michigan. Dr. Wagner, thank you very much for joining us. Um, your study beautifully demonstrated that the woman with significant TR may be undertreated at the time of undergoing mitral valve surgery. First, what inspired to design and pursue this study?
Well, thank you so much, Dr. Mori, and to the whole JACC team for having me on to talk more about this study. To kind of go back and take a 10,000-foot view, women with cardiovascular disease have worse outcomes and have for decades. And even within cardiac surgery, they have worse outcomes across CABGs, valves, aortic work. And I became really interested in understanding why this was. And so I began thinking about this during my research time and broke it down into the preoperative, intraoperative, and postoperative phases of care about where are gaps that can be modifiable to improve women's outcomes. And as a surgeon, I became most interested in this intraoperative phase of care. And I've done some work both at my own institution as well as within statewide quality collaboratives that suggest that women receive don't receive the same quality of operations as men, meaning there might be some opportunities to improve the kinds of operations that we offer to women. I specifically became interested in tricuspid disease and concomitant tricuspid repair at the time of mitral surgery, primarily because mitral surgery is one of my areas of interest. But also I really wanted to understand how guidelines might be driving these differences in the kinds of operations men and women receive. And within guidelines, specifically the size thresholds that we often use to determine if a patient should or should not get cardiac surgery. For tricuspid disease, concomitant tricuspid repair at the time of mitral surgery or left-sided valve surgeries recommended always for severe TR, but has a grade 2A recommendation for moderate TR with annular dilation. And annular dilation is defined both using an absolute size threshold of 4 centimeters and an index size threshold of 21 millimeters per meter squared. But the absolute size threshold of 4 centimeters is most commonly used within clinical practice. So I became really interested to see, does this absolute size threshold, is it potentially driving differences in tricuspid repair during mitral surgery? And is this potentially a modifiable gap that we can narrow to improve women's outcomes?
That's great. Thank you very much for the background and sort of events and rationale leading to the design of the study. I think you designed this study beautifully, and it is something that's very testable and also potentially get at the mechanistic aspect of the sex-based difference that we see across the domains of cardiovascular care, as you alluded to. So, could you describe the key findings and in the study itself?
Absolutely. So our study had three main findings. Number one, women with moderate or severe TR undergoing mitral surgery were less likely to get tricuspid valve repair than men. Number two, women had a smaller absolute tricuspid annulus than men, but a larger tricuspid annulus when it was indexed to their body size. So using that 4 centimeter threshold to define a dilated tricuspid annulus, women were less likely to meet criteria for a dilated tricuspid annulus, but more likely to meet criteria for a dilated annulus when using the indexed body size. And women actually presented with more significant TR. Women were more likely to have severe TR versus moderate TR than men. So it suggests that the use of this absolute size threshold may be inadequate in capturing the severity of valve disease for women. Third, our risk adjustment showed that use of the absolute size criteria to guide surgical decision-making in should we perform a tricuspid repair or not was really what was contributing to the sex differences that we saw in the rates of tricuspid repair. So use of an indexed tricuspid annulus will may better capture the severity of tricuspid disease in women, and it might also narrow gaps in treatment of tricuspid valve disease.
I see. Thank you. I wanted to point out that your Venn diagram beautifully demonstrate this difference that among women, even those meeting the index threshold had actually a lower proportion undergoing tricuspid valve surgery at the time of mitral valve surgery compared to those meeting the absolute threshold. So I think it is a testament to one of your points that although both absolute and indexed values are mentioned in the guideline, what is commonly practiced clinically is by the absolute threshold. And that is, I think, a nice sort of pointer towards the mechanistic pathway of why this difference might be. So I just wanted to highlight this figure for people who are watching or listening, and I hope to see this figure in many conference talks to come. So how would this finding change your clinical practice and also for your research endeavor? Should we be emphasizing, studying more index dimension-based intervention threshold across other domains of cardiac surgery and structural spaces?
Absolutely. And I think you've hit the nail on the head, Dr. Mori. I think that we need to shift away from use of these absolute size thresholds and move towards an index size threshold, both within tricuspid surgery, where there's better data surrounding the index size threshold to define a dilated tricuspid annulus. I think this study, suggests that while more research is needed, greater familiarity, more promotion, use of the index tricuspid diameter to define a dilated annulus will probably narrow gaps in care for women and potentially improve their outcomes. But I think moving past just tricuspid disease, many of our guidelines for surgical intervention rely on size thresholds, for example, LV dilation. And I think continuing to look at how can we personalize our guidelines instead of just saying a one size fits all. That'll just not only narrow gaps in care for women, but it'll really lead to improved and more personalized, specialized care for all of our patients.
Great, wonderful. I think that's a great summary. And finally, maybe switching gears a little bit, I think you are in a unique position, as a trainee, and I have been following your work. You have been extremely productive, during your training, which is very impressive. Do you have any advice or insights for your fellow trainees to keep up the academic output while being in training?
Oh, that's a good question. I think the key for me has been to find something I'm really passionate about. I'm really passionate about this area of work. It's a problem improving the quality of care and narrowing gaps in care for women with heart disease is something that keeps me up at night. I'm excited to study it. I'm excited to find the answers of how we can improve care, and I'm excited to disseminate that work. And so I think if other residents interested in research find something that really motivates them, the productivity will just come.
Thank you. I look forward to learning from more of your work to come. So, all right. Well, Dr. Wagner, thank you very much for joining, and thank you very much for describing this impactful study. Again, I look forward to seeing your future works.
Thank you so much, Dr. Mori.
Thank you.